Good afternoon. I'm Janice Zimmerman, and it's my pleasure to be here for this 24th International Forum of Critical Care. And the topic I wanted to review with you today is not about the lung, it's about thrombotic thrombocytopenias, particularly heparin-induced thrombocytopenia, vaccine-induced thrombotic thrombocytopenia, and even a little bit more. I have no conflicts of interest related to this topic. So the three conditions that I want to review with you, of course, first is heparin-induced thrombocytopenia, and then a condition called autoimmune or spontaneous heparin-induced thrombocytopenia, and I hope as you'll learn that that's a very inappropriate name for that condition. And then last, the vaccine-induced thrombotic thrombocytopenia associated with COVID vaccination. By the end of this, I hope to convince you that a better name for these conditions is actually immune thrombotic thrombocytopenias mediated by platelet factor 4. So let's start with heparin-induced thrombocytopenia. This occurs, of course, with all heparins when they're exposed. We know it occurs more commonly with unfractionated heparin than low molecular weight heparin. And we see a typical evolution of this condition. Usually patients present with thrombocytopenia 5 to 10 days after exposure to heparin, the median being 6 days. Also, if they've had a prior exposure to heparin in the preceding 3 months, this may occur much earlier. By 8 days, we see the platelets have decreased to greater than 50%. And if they're going to develop thrombosis, we'll usually see that a median of 10 days after heparin was started. In general, with heparin-induced thrombocytopenia, it's a moderate thrombocytopenia, with the average level being about 40,000. And you don't often see values as low as 10 and 20,000 in this condition. Now, I'm going to spend a little bit of time talking about the mechanism, because as you see, we'll use that same mechanism to explain some of the other conditions. First of all, heparin binds to platelet factor 4. Platelet factor 4 is a positively charged compound. Heparin is negatively charged. So this forms a heparin platelet factor 4 complex, and that heparin actually induces a conformational change in platelet factor 4. And due to that change in the structure of platelet factor 4, antibodies, an IgG antibody is developed and produced against that heparin platelet factor 4 complex, and that creates an immune complex of the antibody, heparin, and platelet factor 4. Now, what happens with these immune complexes, they form actually multimers on the surface of platelets, and they actually cause an interlacing cross-linking of these compounds with the Fc receptor on platelets. And although this picture has just one of these complexes, picture a platelet with many of these complexes on the surface. And what that leads to is activation of the platelet, also apoptosis, and also elimination of these platelets by the spleen. But you also have to remember that it's not just platelets that get activated by these immune complexes. These complexes also bind and activate monocytes, endothelial cells, and neutrophils. So you can see that this plays a role in the inflammatory response to many of the conditions we see, like infection or other traumatic events. Now, these antibodies and heparin-induced thrombocytopenia are a little unusual. There's not a typical sequential production of antibodies, starting first with IgM and then switching to IgG. And this suggests that there's some type of endogenous exposure that leads to IgG being present initially. Now, you can see all classes of antibodies, and they can all occur at the same time. But you can also see one or two, and not necessarily all three, but only the IgG antibody is associated with clinical heparin-induced thrombocytopenia. These antibodies disappear within 3 to 6 months. after heparin exposure stops. And it's interesting that on re-exposure to heparin, you may actually not see these antibodies develop again. So usually the first suspicion of heparin-induced thrombocytopenia in your patients is a decrease in platelet count. But also, if you see the presence of a thrombosis in the presence of heparin, it should make you think about this, and the presence of unusual thrombosis, such as we're seeing with the vaccine-induced thrombotic thrombocytopenias. When do you discontinue heparin? While you're waiting on test results? Well, if your platelet count has already decreased to less than 50,000 or decreased by 30 to 50%, you'll see various recommendations. If they have thrombosis, and about anywhere from 30 to 80% of patients will develop thrombosis, rarely would you see hemorrhage. That occurs in less than 10% with heparin-induced thrombocytopenia. But these are all situations where you want to stop heparin while you're pursuing diagnosis. Now, the diagnosis of heparin-induced thrombocytopenia occurs in 3 steps. First step is looking at the risk factors in your patient and using a probability score or pretest probability. So what are the risk factors? Well, these you also are probably familiar with. Higher risk in cardiovascular, in orthopedic surgery patients, high risk in ECMO patients. It's more common in women than in men, and it's more common with unfractionated heparin than low molecular weight heparin and fundaparinux. We also know that the higher the dose, so therapeutic doses, more likely to be a risk factor for heparin-induced thrombocytopenia than prophylactic doses. Also, patients who are exposed to therapy for a longer period of time. And then we combine those risk factors with a probability score. There are really 3 scores out there. The most commonly used is the 4T score, and this is the score that's recommended by the American Society of Hematology. There are some limitations. It's less reliable in cardiac surgery patients, and you can see variability in how it's applied by different evaluators. So I would say that no single score or risk factor should dissuade you from considering the possibility of heparin-induced thrombocytopenia. There's also a heparin-induced thrombocytopenia expert probability score, and this was actually developed by people who are considered experts in this condition, but it's much more complex and it requires more time to calculate, and it has not been prospectively validated. So it's out there, you can look it up on the internet, but it's not commonly used. There's also a separate score for cardiopulmonary bypass patients. And this score takes into account the relation of the platelet count with the date of cardiopulmonary bypass and also the duration of cardiopulmonary bypass. Now, the next step in diagnosis of heparin-induced thrombocytopenia is an Elisa Immunoassay. This type of assay detects the antibodies against the platelet factor 4 heparin compound. Now, these assays can be polyspecific and pick up all classes of antibody, or they can be specific for IgG. You might want to check with your laboratory and see which one you have. The one specific for IgG is considered to be better in that it is specific for the pathologic antibody. These antibodies in this test actually bind not to heparin, which is not used in the assay, but a polyvinyl sulfonate. That's important to keep in mind because this polyvinyl sulfonate is another negatively charged anion like heparin. As the measurement is often due to optical density, and many of these tests have a threshold optical density that predicts a very positive result for heparin-induced thrombocytopenia, and also predicts a positive result on a functional assay that we'll talk about next. That optical density correlates with the amount of antibodies present. So a higher number of antibodies gives you a higher optical density. Now, these tests have high sensitivity, but low specificity. So in patients, cardiac surgery patients, cardiovascular surgery patients, you'll find this test to be positive in up to 50 to 60% of patients. And we're also seeing this test positive in up to 10 to 20% of patients with COVID-19. So that's the limitation. So if you really want to know specifically that you have a pathologic antibody, the third, excuse me. Oh, forgot to mention, these are the rapid assays. So we talked about the Elisa assay. There have been several other assays developed that are more rapidly performed. And this could be gel particle immunoassay, a chemoluminescent assay specific for IgG, or a lateral flow immunoassay. And a meta-analysis did suggest that these have good sensitivity and specificity, but these are tests that actually can't be used when you're concerned about vaccine-induced thrombotic thrombocytopenias. So there are limitations to these tests. But the third step, the ultimate test in diagnosing heparin-induced thrombocytopenia, is a diagnostic functional assay. And these assays evaluate the ability of antibodies to induce platelet activation in the presence of heparin. So it detects heparin-dependent activating antibodies. So these assays have high sensitivity and specificity for diagnosing heparin-induced thrombocytopenia. Now, the problem here is that they are more expensive and they're not widely available in all hospitals. There's also not been good standardization of these tests from laboratory to laboratory. So the two types of assays for functional tests are the serotonin release assay and then the heparin-induced platelet activation assay. So let's just talk a little bit about the serotonin release assay, because this is probably the more commonly used and the one that you'll see referenced in literature. So in this assay, platelets are labeled with serotonin C14. They're incubated with the plasma from the patient and two different concentrations of heparin, a low dose consistent with therapeutic heparin doses in our patients, and a high dose of heparin. So serotonin is released at the low concentration of heparin when there are antibodies present that activate platelets. Now, this is also confirmed by the fact that with high doses of heparin, this high dose actually inhibits the release of serotonin when there's platelet activating antibodies present. So they have to have both a positive with the low dose heparin and a negative with the high dose heparin. Now, false negatives have been seen with some of these tests. So again, you have to keep this in mind with your patient. Now, the heparin-induced platelet activation test is a little simpler. It takes the plasma of the patient and add it to platelets in the presence of heparin. If it's positive, you have aggregation of platelets, but these tests have actually been found to be falsely negative when antiplatelet agents have been present in the plasma of the patient, such as ticagrelor and some of the other antiplatelet agents. So let's say our tests show we have heparin-induced thrombocytopenia. What do? I think you're familiar with this management algorithm. Discontinue heparin. You anticoagulate even if there's no obvious thrombosis because the risk is so high. The anticoagulant that you choose may depend on what's available to you. Argatroban is probably the most commonly used in the United States. Bivalirudin has also been approved, but primarily for use in percutaneous interventions, but it's been used off-label. Fundaparinux has been used, but it's not approved for that indication. And we've seen more reports of using direct oral anticoagulants, although it's not approved by the FDA. The most commonly used one that you may see reported has been rivaroxaban. Warfarin should not be used until the platelet count returns to normal. The other part of managing is obviously to try to avoid transfusion of platelets and only consider that option when there's severe bleeding. You should also avoid inferior vena cava filters because these actually predispose to more thrombosis. Now, that's the typical management that most of you have to use, and you don't have to consider other options. But there are other options for difficult cases that you need to be aware of, and you're going to see this approach used in some of the other conditions. So IVIG, this removes the antibody, binds and removes the pathologic antibodies. When should you consider it? Well, if you have clinical worsening while the patient's on anticoagulation, or you're unable to anticoagulate the patient. Plasmapheresis can also eliminate pathologic antibodies, and it's considered when there's a need for immediate cardiovascular surgery that requires heparin, and also when you're unable to use another anticoagulant, or that patient is worsening despite anticoagulation. Now, another less commonly kind of referenced intervention that's only more recent is the use of Congrelor, which is a reversible inhibitor of platelets. Where you'll see this reported is with cardiovascular surgery in patients who already have known antibodies to heparin platelet factor 4, but they have to do surgery and they have to use heparin. So keep that in mind. It's going to be more likely used in surgical patients. Now let's talk about another condition that's often been referred to as spontaneous or autoimmune heparin-induced thrombocytopenia. That is a totally inappropriate name, but that's what it's been. So many of you may have sometimes seen a patient where you thought they had heparin-induced thrombocytopenia, but they were never exposed to heparin. So they may have this condition. This is where they usually present with thrombosis, and the thrombosis leads to laboratory testing that shows the thrombocytopenia. And there's two different clinical scenarios that you'll see reported. In surgical patients, primarily orthopedic surgery, and the number one surgery here is knee replacement, and also in cardiac surgery patients. You'll also see this in a medical patient with infection. And here, the antibodies that are produced, again, they are produced, it's an immune phenomenon, and they bind to platelet factor 4, and they activate platelets in the absence of heparin. And what these are antibodies that bind to a combination of platelet factor 4, which is bound to another anionic substance, another polyanion. So it's not heparin, it's a polyanion. And we think that these may be due to naturally occurring polyanions such as lipopolysaccharide from bacteria, glycosaminoglycans, which could be released in orthopedic surgery, and even bacterial RNA and DNA can be polyanions that bind to platelet factor 4 and induce this formation of antibodies. Well, how do you test for this type of condition? Well, it's not particularly easy. You can use the Elisa Immunoassay for IgG, and it's usually going to be positive. But this compound here that it binds to is now a polyanion platelet factor 4 combination, not heparin. Now, one way to detect this condition is to add heparin to this Elisa Immunoassay. Unfortunately, that's not a standard procedure, and it's typically not done. Well, this condition will also cause a positive result in the serotonin release assay. But if you actually were thinking about this type of condition, what you want to do is get a positive result without adding the heparin to the assay. And what that shows you is that you have a heparin-independent antibody that activates platelets. Well, this type of condition is probably what you're seeing also reported in COVID-19. Of course, patients with COVID-19 are exposed to heparin. There's been multiple reports of COVID-19 patients with heparin-induced thrombocytopenia that never had exposure to heparin, however. If you'll look at these reports, you'll see that there are primarily positive ELISA immunoassays, although some have reported to be negative. But frequently, they don't go on to do a platelet activation functional assay in their patients, and they just report it as heparin-induced thrombocytopenia. Even in the serotonin release assay, you're going to get a positive with these patients, but they don't generally test using the serotonin release without heparin being present. And that would be the key to know that you're dealing with some other type of antibody that doesn't require heparin, but still activates platelet factor 4. Well, what is the stimulus for this assay? Well, again, in COVID-19, it may be due to the endothelial damage and release of glycosaminoglycans, but that still has not been determined. How do you manage spontaneous or autoimmune heparin-induced thrombocytopenia? Well, very similar. You want to anticoagulate because of thrombosis. You have to use an alternative anticoagulant. And theoretically, you might consider using heparin because heparin actually doesn't activate that antibody. But just to be sure, most people would suggest not using heparin, although there are some orthopedic patients that did get heparin. You also, in these patients, because the high risk of thrombosis, you want to interrupt that activation of platelets that's mediated by that FC receptor. So here you're going to use IVIG in high doses. The typical dose is 1 gram per kilogram per day for 2 days. If the patient worsens, then plasmapheresis can be considered. Well, the last thing let's talk about is vaccine-induced thrombotic thrombocytopenia. The criteria for diagnosis you may be familiar with, although this is an evolving type of syndrome, we want to keep on top of the changes. But currently, this is kind of the diagnostic criteria that are proposed. We see an adenoviral vaccine within the last 30 days. Thrombocytopenia, usually it's moderate or severe, and the presence of thrombosis. And as you know, these are frequently unusual thrombosis, cerebral venous sinus or splanchnic veins, and a positive result on an platelet factor 4 heparin antibody. So an Elisa Immunoassay positive. Now, this has some similar features to heparin-induced thrombocytopenia and some differences. It begins 5 to 30 days post-vaccination, with the majority within 14 days. So that's similar to heparin-induced thrombocytopenia. It's moderate to severe thrombocytopenia. But a unique feature of these patients is that there's a very high elevation of B dimer, and more of these patients demonstrate abnormal parameters consistent with disseminated intravascular coagulation. The fibrinogen can be low or normal in these patients. So it appears to be somewhat similar to what has been called spontaneous heparin-induced thrombocytopenia. So what about tests for vaccine-induced thrombotic thrombocytopenia? So if you test with an Elisa Immunoassay that we typically use for heparin-induced thrombocytopenia, it will be positive. What's interesting is the rapid immunoassays will be negative and should not be used. And the reason it's going to be positive, they've just published this in Nature. Here's the antibody where it binds in red from the vaccine-induced thrombotic thrombocytopenia patients, and it binds in this area of platelet factor 4. In this lower one, this is where the antibody for heparin-induced thrombocytopenia binds. So you can see that it binds in a similar spot, but it's a different antibody. So this assay is going to be positive. The functional assays for platelet activation will also often be positive, although the serotonin release assay has been reported to be negative in some. Once again, if you want to find out if this is a heparin-independent antibody, you have to evaluate a functional assay without the addition of heparin. Then if you actually add high dose or high or low dose heparin in this assay, it will inhibit the activation. So heparin will bind that antibody and prevent it from binding to platelet factor 4. So in the vaccine-induced thrombotic thrombocytopenia, the immune stimulus that starts this process off is not yet been identified. Potential candidates have been some combination of spike protein with other naturally occurring substances, the adenoviral sequences as well, although, again, no one is sure yet. Well, I'm sure we'll learn more about this. Now, when do you treat these patients with vaccine-induced thrombotic thrombocytopenia? Well, if you have thrombocytopenia, thrombosis, and a positive Elisa Immunoassay, you should treat. If you have thrombocytopenia and thrombosis and you're still waiting on a test result, you should probably go ahead and treat because your clinical suspicion is going to be high. There's also another situation where you may consider treating, and that's when you have thrombocytopenia, a positive Elisa Immunoassay, and with or without a high or elevated D dimer, even when you don't have thrombosis. So again, the indications for treatment are changing, so you need to keep your kind of ear to the literature and the reports coming out. But again, I think the message here is that if you have a high clinical suspicion, even in the absence of thrombosis, if you have that positive immunoassay, which looks like heparin-induced thrombocytopenia, you should go ahead and treat these patients. You'll notice that the treatment of these vaccine-induced thrombotic thrombocytopenias is very similar to what we call the spontaneous conditions. You anticoagulate, and what you'll see in the literature right now is argatroban, bivalirudin, and you'll also see a little bit more of the 10A inhibitors being used. The preferred treatment is IgG in high doses for that 2-day dose given to these patients. Whether you do plasmapheresis in addition to IgG will probably depend on if you have it available and also the condition of the patient. It is recommended to avoid heparin, even though heparin doesn't necessarily activate the platelet factor 4, and similarly avoid transfusion of platelets. Now, what about steroids? Since this is the production of an antibody, should we give an immunosuppressant drug? Well, this is still being considered. You'll see some people reporting use of steroids, but you might consider the use of steroids, particularly when you don't have access to IVIG or you don't have access to plasmapheresis. So keep in mind, and both prednisone and dexamethasone have been reported, again, only a few case reports. So I'm going to leave you again with my thoughts about how to think about these thrombotic thrombocytopenias. Again, I think keep in mind they're all immune and they all are mediated through platelet factor 4. But what we have is different stimuli. In some, we know what the stimulus is, or you could think of this as those conditions with an exogenous stimulus, and that's the heparin-induced thrombotic thrombocytopenia. I'm adding an extra T here. And we also have the vaccine-induced thrombotic thrombocytopenia, again, an exogenous stimulus. The patients, I think, in the condition that we're most likely to miss are those where we don't know the stimulus. This is the entity previously called spontaneous heparin-induced thrombocytopenia, but it's not heparin-induced. So I like the term idiopathic thrombotic thrombocytopenia. And again, I think if you're seeing a platelet count go down, you're seeing unusual thrombosis with no exposure to heparin, think about this type of condition and try to diagnose and treat appropriately. So I'll stop there. Thank you for your attention, and I'm happy to answer any questions.
Good afternoon, Doctor. Thank you so much for your presentation. We have just a little time left, maybe for a couple of questions that arose during your presentation. One of them is when there is VIT, vaccine-induced thrombotic thrombocytopenia, plasmapheresis protocols you're familiar with, which are the doses they're using, and how is this treatment carried out?
Interestingly, there's no standardization at this point because it's such a new entity. I think many people are starting with standard doses that they might use for other conditions. But I think we'll see this kind of develop. It's also not clear how many sessions of plasmapheresis are needed. I think most are just starting with a single session of plasmapheresis. But remember, that's usually in addition to IVIG. I haven't seen anyone using plasmapheresis or reporting the use of plasmapheresis without IVIG first.
Thank you so much, Doctor. There is this question also. Is there any theory stating that VITT would have this preference for sagittal sinus? Do you know why? What the reason for that is?
So I don't know why, but there are some theories that have been proposed. And one is that whatever the antigen is, whether it be part of a spike protein or a combination of spike protein and another, maybe glycosaminoglycan, that this antigen actually is able to circulate into and cross the blood-brain barrier or in the endothelial, and that somehow predisposes those sites. But to be honest, it's really not known. But again, I would say that the resemblance of vaccine-induced thrombocytopenic thrombotic thrombocytopenias to what we have called spontaneous suggests that there's something endogenous that is reacting with that exogenous antigen to produce that stimulus for the antibody. And I'll also just, I failed to mention that I'm sure hopefully most of you have been vaccinated, but with the adenoviral vaccines, they have done studies in healthcare workers after vaccination, and about 8% of the healthcare workers developed antibodies that were positive in that Elisa Immunoassay. So these antibodies are being produced, but they're not the antibodies that activate platelets. So again, there's a lot of factors that go into developing what we would call that pathologic antibody that activates platelet factor 4.
Thank you so much. These are very interesting phenomena. I'm sure we will get more information in time and we will have more certainty about these phenomena. Okay, Doctor, thank you so much. Now we will move on to our next presentation.